Hello everyone, welcome to the channel. This is Clinical Reasoning series. I am going to discuss the case number 5. Before I start the discussion, please note that this discussion is only for academic purposes and cannot be directly related to the patient care. This is the brief clinical scenario. The expanded version and the full version of the question is available in the Telegram group, the link of which I have shared in the description below. So, this is a 50-year-old female with the complaints of 6 weeks history of cough, exertional dyspnea on and off. Now, the patient also says that this complaint is progressive. Okay, it is increasing. Okay, it is increasing. That's called progressive. And you can see the rest of the history. It is given that she is a non-smoker. Remember, this is a very important clue for you in the question because most of the conditions in the respiratory system we relate it directly or indirectly to smoking. So that is why always a history of a smoker or a non-smoker is very important. In this case, it's a non-smoker. Other history given is she's a known hypertensive controlled with metoprolol for past 5 years. Okay, so one more significant history is she's a hypertensive patient also. Now you look at the last part, that is even more important. What is written? Recently, that is 2 months back, she had an episode of atrial fibrillation and was put on amiodarone as a part of the treatment. Okay, right. So we have a 50-year-old female who is a non-smoker having progressive respiratory complaints. She is a hypertensive and she has been recently started on amiodarone as well. Okay, right. Now look at the examination finding. She is febrile. BP is 130/80 millimeters of mercury, which is fairly okay, controlled hypertension. Heart rate is 82 per minute, which is also normal. Respiratory rate is 16 per minute. SpO2 is found to be 92% in the room air. All these are under control, it's normal. Now you can see the examination finding. Bilateral basal crackles or crepitations are here and the heart sounds are normal is what is given in the question. Lab investigation findings are also given. Have a look at it. Hemoglobin is 12, which is okay. WBC count is 11,000, that's also okay. With 55% neutrophil, 30% lymphocyte, all these are okay. But what is given here? 9% of neutrophil, which is something like increased amount of neutrophils for this particular patient. Chest X-ray reveals diffuse bilateral infiltrates with basilar predominant. That means what? There are infiltrates in the lung fields, but the lung bases are the ones which are predominantly affected. This also correlates with the clinical finding in this patient. What was given? Bilateral basal crepitations are given. So that means the pathology is somewhat in the base of the lungs. So with this history, the question is, what is the diagnosis in this particular patient? Now when I put up this question in the Telegram group yesterday, many of you were answering it. Most of you had confusion between the last two options. What are the last two options? Acute eosinophilic pneumonitis and drug-induced lung toxicity. Many of you were able to rule out the first two options, pneumoconiosis and congestive cardiac failure. Now, I'll come to the last two options. First, let us rule out those easy ones, that is pneumoconiosis. What is pneumoconiosis? It's something which is an occupational exposure to some agents and they are causing a lung disease. How can I exclude that in this particular patient is because usually the history is not like a short duration. For example, in this particular question, the history of the complaints were for 6 weeks. Okay, 1.5 months. Are you able to follow this? In case of pneumoconiosis, is a chronic condition where it will be over a period of few months or years. Are you able to follow? Number one. Number two is that there is a latency period between the exposure and the development of the conditions. Okay, and the development of the problem. This latency period is long period. It is 20 to 30 years. Okay, so in the history you will be getting a typical clue in the form of a person working in the industry or industrial worker like that would be given. However, in this particular question, that female was a homemaker, housewife, so she is no way going to be having pneumoconiosis like picture, and that can be ruled out. And one more thing I would want you to remember is that in chronic conditions, okay, like this pneumoconiosis and all, there is usually associated clubbing also, which is not given in this particular question. So that is why we can very clearly and easily rule out pneumoconiosis in this particular patient. How did you rule out the next option, that is congestive cardiac failure? congestive cardiac failure, there were no classical signs of congestive cardiac failure. For example, there was no history of orthopnea. There was no history of jugular venous distension or JVP elevation. Nothing was given. And there was no additional heart sounds or murmur. Okay, especially if it was a congestive cardiac failure, they would have given this S3 gallop and all. That was not given in this particular question. And also, this patient had eosinophilia, increased eosinophils, as well as fever, which cannot be accounted by congestive cardiac failure. So that can be ruled out. Okay, so very easily you are able to rule out the first two options. Now the confusion is between C and D. Equal proportion chose acute eosinophilic pneumonitis and equal proportion chose drug-induced lung toxicity also. So let me tell you what is the answer, then I will discuss this question subsequently. The answer is drug-induced lung toxicity. Remember, drug-induced lung toxicity is actually a diagnosis of exclusion of other known condition. So before I have to diagnose drug-induced lung toxicity, I should exclude the other condition, including the one which is given in the question. What is it? Acute eosinophilic pneumonitis. So how I exclude acute eosinophilic pneumonitis? Remember this point. Acute eosinophilic pneumonitis will have a severe presentation. Okay? And it's something which mimics the presentation of ARDS, acute respiratory distress syndrome, where the patient would land directly in the ICU. But in the question which we are discussing, the patient was relatively stable. Are able to follow? All the vital parameters were stable. BP was under control, saturation was normal, heart rate and respiratory rate, everything was normal. So that means it was not a severe condition. That itself will tell you that this is not an acute eosinophilic pneumonitis. Second thing is, it's a rapidly progressive. I agree in this particular question, the symptoms were progressive, but it was not given like rapidly progressive symptoms. Okay, or in other words, it was not like an acute condition. More of like what I can say is a subacute condition in this question. But acute eosinophilic pneumonitis, rapidly progressive acute condition. Okay, and the third point I would want you to remember is that in acute eosinophilic pneumonitis, if you take the X-ray, it will show more of infiltrates in the periphery. Peripheral infiltrates are the characteristic finding. But in this question, nothing like that was given. It was given just as a vague statement. Diffuse infiltrates were present in the lung fields. Okay, so that is also a point against acute eosinophilic pneumonitis. Okay, right. And the very, very important point I would want you to remember is that it is a line taken from Harrison's textbook, which very clearly mentioned that in patients with acute eosinophilic pneumonitis, when compared to other conditions associated with eosinophilia, in this particular condition, peripheral eosinophilia is often not seen. That means what? Peripheral eosinophilia means eosinophil accumulation or increase in the blood, peripheral blood is not there. That means if you take the blood count, the peripheral eosinophilia is usually not present. Are you able to follow? But in this particular question, I clearly mentioned that eosinophil count is 9% or it is eosinophilia. What Harrison clearly mentioned, peripheral eosinophilia is usually not present at the time of presentation in case of acute eosinophilic pneumonitis. So then, how can I make the diagnosis of acute eosinophilic pneumonitis? It is by examination of bronchoalveolar lavage, which reveals more than 25% eosinophils, and that is the diagnostic finding in this particular condition, without which you can never make a diagnosis of acute eosinophilic pneumonitis. So bronchoalveolar lavage reveals more than 25% eosinophil is diagnostic of acute eosinophilic pneumonitis. So none of this were given in the question, so that is why I am able to confidently rule out acute eosinophilic pneumonitis. And that brings me to the diagnosis in this particular case, which is drug-induced lung toxicity. So two drugs were mentioned in the question. One, the patient was having metoprolol for hypertension, and second, for atrial fibrillation, she was also put on amiodarone. Can anybody tell me which drug would have caused that lung toxicity? Yes, you would have guessed it correct by this time. It is amiodarone. Most of you might have known about amiodarone-induced thyroid dysfunction. It can be associated with hypothyroidism as well as hyperthyroidism. But equally important for you to remember is that amiodarone also can be associated with lung toxicity. And what is that lung toxicity? In the form of interstitial lung disease, ILD. interstitial lung disease. At this point, I would also want you to remember other important drugs which can be associated with interstitial lung disease. One is the anti-neoplastic agent bleomycin. Second is antibiotic nitrofurantoin. These are very, very important for your exam, often asked in the competitive exam, so please make a note of it. And one more important point regarding this drug-induced lung toxicity is that you again go back to the question. You see here, the patient had a history, 6 weeks history of the respiratory complaint like cough and exertional dyspnea. And when do you think the amiodarone was started? It was started 2 months prior. So it is almost the same time after starting of amiodarone, the patient had symptoms. This is also one more finding in case of drug-induced lung toxicity. What is that? There is a temporal association. There is a temporal association between the exposure to the drug and the development of lung symptoms. This is what we call it as a temporal or a time-related association. The time at which the drug was introduced to the patient roughly corresponds to the time at which the respiratory symptoms have started. So 2 points. One is temporal association. Second is it's a diagnosis of exclusion. In this particular question, I have excluded all the other conditions. So that is why my diagnosis is drug-induced lung toxicity. So this is the approach to this type of clinical scenario-based question which I have discussed. Hope you have liked this video. If you have any question, put it up in the comment section. Please subscribe to this channel and press the bell icon to get notified about the new videos which are posted to this channel, and feel free to share with your friends. I will see you in the next clinical reasoning scenario based question. Thank you and have a good day.